away from corneal infection and ocular surface disease and focus briefly on corneal ectasia. Actually, I was ordered to skip the corneal dystrophies part, so I will basically provide infos about the corneal ectatic disease. So how would we define corneal ectasia today? The Delphi panel on Keratoconus has defined precisely the criteria to set the diagnosis of corneal ectasia. So it has to be clinically evident, non-inflammatory thinning of the cornea, an abnormal posterior elevation, back elevation, posterior surface of the cornea, and an abnormal corneal thickness distribution. And there is a number of diseases actually included in the general term corneal ectasia, each one of them having actually their own characteristic, but also some common findings. Now, let me remind you about keratoconus, that it's not an uncommon disease. Particular areas of the world, like Saudi Arabia, but even Greece, have a relatively high incidence of keratoconus. It's always bilateral, although there is an asymmetrical manifestation of the disease, so one eye is more affected than the other. And the clinical hallmarks actually are referring to thinning and stiffening of the cornea with displacement of the corneal apex. Now, which are the ocular visual disturbances for the patients suffering from keratoconus? Increasing myopia and irregular astigmatism. So these patients normally go to the optician complaining of increasing myopia and very often changes in the axis of their astigmatism, so asking for a new pair of glasses. There's a number of causes implicated in the pathophysiology of keratoconus, but we have evidence that it's basically a genetic disease, and all other associations are more or less in terms of there are clinical correlations, there are epiphenomena and not diseases which are actually have a pathophysiological connection with keratoconus. Now, what can we advise our patients to do or not to do in order to prevent progression of keratoconus? So the only thing that they can do is stop eye rubbing. So we know that eye rubbing is a major cause for progression of the disease, and there are also studies implying that it could be also the trigger for development of keratoconus. Apart from this, actually, it's nature that's deciding whether keratoconus will occur or not, and whether it will progress or not. Now, about progression patterns of keratoconus, we know that it's very aggressive in children. Typically, tends to be clinically manifest in adolescents with 13, 14, 15 years of age, but it's not unusual to see children with 7, 8 years of age having keratoconus. And it's also typically arresting with 34, 35 years of age. By that time, there is a natural stiffening of the cornea having occurred, but we also see patients at late 30s with progressive keratoconus, and of course there are patients with first diagnosis of keratoconus at age of 40 and above. Now, how do we diagnose keratoconus? Slit lamp examination is not adequate for early diagnosis. By the time that we observe the Vogt striae and the apical haze and maybe the Fleischer ring, it's already advanced. So slit lamp examination is actually for the late stage of conus to assess our patients. Anterior segment tomography is also not sufficient enough for early diagnosis. It's useful, for example, for evaluating corneal eye drops and treatment after cross-linking, but not for early diagnosis. So here you can see, for example, patients with eye drops and status after cross-linking with demarcation line. Now, what is the gold standard for early diagnosis? It's the Placido Scheimpflug camera, so corneal topography tomography. And we can use as an additional tool to support our diagnosis to the corneal biomechanic imaging. So we can evaluate corneal biomechanical properties in vivo with ocular response analyzer and Corvis in cases where we're not really sure whether our cornea has an ectatic profile or not. Finally, we have also the option of epithelial mapping, corneal epithelial mapping, which is or has been introduced as a promising diagnostic tool, but there are several issues with this diagnostic approach. And I don't know about you, but Bruce or Miltos, but I'm not really fan of or convinced about the diagnostic validity of epithelial mapping for early diagnosis of keratoconus.
I think we have to wait.
Yeah.
The OCTs that we have now are not so reliable.
There is consensus that corneal topography is a gold standard, enhanced with corneal biomechanic evaluation of the cornea. And what do we observe in corneal topography? We observe an area, as you all know, of increased stiffening of the cornea with an infero-superior asymmetry of more than 1.5 diopters. We have corneal thinning with displacement of the thinnest point of the cornea from the corneal apex. And most important, we have back elevation. So I have an elevation of the posterior surface of the cornea of more than 14, 15 microns. And this is actually a must-see finding for the diagnosis of keratoconus. There are many different metrics in corneal topography for enabling this, the diagnosis, but if we just stick in our practice, for example, to these three clinical findings, then we have to 90%, we have a secure diagnosis of our keratoconus patients. So here you can see, for example, another case of superior keratoconus, which also exists. It's a new entity, actually has been described more than 15 years ago, but it's a new entity now that is being also characterized biomechanically, and it seems that it has different progression pattern and different etiology compared to the classical keratoconus as we know it. And there are also other variations from the typical keratoconic ectatic cornea. We have the form-frust keratoconus, where we see only minor changes, for example, in the posterior surface of the cornea. And there we need to use actually corneal biomechanics in order to facilitate valid diagnosis. Or we have some tricky corneal entities, such as corneal apex displacement syndrome or normal thin cornea or funny corneas, where actually the diagnosis is not so clear. And this is a case of Pellucid marginal degeneration, where sometimes also the borders between PMD, Pellucid marginal degeneration, and keratoconus are not very clear. And then we talk about pseudo-Pellucid marginal degeneration, for example. So in all these borderline cases, the use of anterior corneal topography is not sufficient, and then we need to have additional information from corneal biomechanics. Nowadays, as I mentioned before, we have only access to, in clinical practice, to ocular response analyzer and Corvis. But I think that within the next 5 years, we'll have advanced tools for corneal biomechanical evaluation, integrating Brillouin microscopy. So these things are coming within the next years. Now, the pellucid marginal degeneration is much more rare compared to keratoconus, also bilateral and asymmetrical. And here we see the thinning in the periphery inferiorly in a crescentic fashion. The onset is later on, with between 20 and 40 years, and we don't know that much compared to keratoconus. We know that it's mild. We know that tends to be not to progress, and if there is any progression, it's slow, so we rarely need to intervene. Keratoglobus is extremely rare. I've seen it only a few times in my career. I don't know about you, Miltos. Have you ever confronted with?
Only two.
Yeah. We don't know a lot about keratoglobus. In keratoglobus, we have corneal thinning of the whole of the corneal tissue. So it's the whole cornea, overall cornea, is protruded and thin. And the prognosis is not good at all. So how do we diagnose pellucid marginal degeneration? Again, with the aid of corneal topography and tomography, where we observe the typical crab claw pattern inferiorly. And of course, we have the post-refractive corneal ectasia, which is not that often, but when it happens, it's a major problem for the refractive surgeon and the patient. It's usually unilateral, but it can be bilateral. And it's becoming clinically manifest with the regression of the refractive error, irregular astigmatism, 1 year, typically between 1 and 2 years after the refractive procedure. What do we observe in corneal topography? We have a central or paracentral area of corneal thinning and steepening. And regarding risk factors, we know that Radleman has described in his ectasia risk score system factors that could contribute to the development of ectasia after refractive surgery. And Santiago Marconi has also presented a metric, an index, the PTA, which could be a relatively good prognostic factor for predicting the risk of corneal ectasia after a refractive procedure. But the unknown factor is always there, so regardless of a very meticulous preoperative assessment and respecting all these guidelines, we can never be sure about the outcome, and we always confront with surprises. So how the LASIK, I have to mention, has a higher incidence of ectasia, post-refractive ectasia, compared to PRK. And how do we diagnose it? Again, with the aid of corneal topography, where again we have the same findings, steepening. In this case, it's a central area of steepening and thinning. And again, we have back elevation of the posterior surface. I have to mention that the back elevation is a finding that we don't necessarily see in post-LASIK ectasia, for example, after a smile. There have been also cases of post-LASIK ectasia without back elevation, and most of the cases of post-smile ectasia also don't demonstrate a posterior surface elevation. So I think we need to revise the criteria for post-refractive ectasia. I don't know from your experience, Bruce, or have you always seen back elevation in post-LASIK or post-PRK or post-smile ectasia?
So it's a new concept for me, actually, the idea that you don't have back elevation. For me, the diagnosis has always been based on that, but that is just my limited experience, I think, there. that's a new concept for me. I'm not familiar with it.
Especially for the smile cases, it was very interesting paper that had Rohit Shetty from India. He had done smile in one patient, 2 eyes, get ectasia after 2 years. Lucky enough, he kept the smile lenticule into his fridge for I don't know what reason. When they went back, there were no evidence pre-op that these eyes would get ectasia. No back elevation, nothing at all. Everything was absolutely clear. So what they did is that they went for biomarkers, and they found out that they have this LOX biomarker, which was full in both 2 lenticules. So I think that soon enough we'll have biomarkers from the tears that may give us another clue of who is going to be a possible suspect of post-LASIK ectasia, and it's not going to be just the posterior elevation. The question is really, if you have a patient with without any evidence and just one biomarker, are they going to exclude them from refractive surgery? We don't know that, but it may appear in the future.
I just want to highlight that back elevation is not a prerequisite for diagnosis of post-refractive ectasia. No. It might be evident in post-LASIK cases of ectasia, might not, but it has never been described in post-SMILE cases of ectasia.
Okay, well then why should describe it? Because we've had several cases come through, and they're classic ectasia cases with back elevation after SMILE. So our sense is that there's no difference between SMILE and LASIK in terms of risk of ectasia. But you can cover that in the debate.
Good. There was a recent paper about examining the biomechanical properties of the cornea after SMILE and after LASIK, and they find no differences at all in terms of integrity of biomechanical structure.
Actually, Hafezi has done the first comparison, LASIK versus SMILE ex vivo. He used elastometry for his experiments, and he showed that LASIK.
We're getting ahead. We're going to have a debate on this, aren't we? Is that right?
No, I'm a winner already, so we don't need the debate, I think.
So I think he showed in a very clear way that SMILE, post-SMILE cornea is 47% stronger biomechanically ex vivo compared to post-LASIK cornea. So I don't think there's debate there. But I move on.
Vincenzo, did you give him?
There's going to be a debate, let me tell you.
I want to help you on the posterior.
I gave them 50 euros each.
After ectasia, so we actually had a few cases with post-LASIK ectasia without posterior elevation, and especially post-PRK ectasias without posterior elevation. The ones that you do have an exaggerated posterior elevation after LASIK are the ones that they were highly suspicious in the preoperative assessment.
But this all is for the refractive course, which is going to be after a week.
We save the discussion for later. So I will finish off with an algorithm showing how a suggested algorithm for approaching corneal ectasia treatment. First step would be to try rigid contact lenses, scleral contact lenses. There are certain patients who are not happy with that. So next step, which would be in patients with stable keratoconus, corneal ectasia, to improve visual acuity. So the major question in the clinical practice when you have a patient with corneal ectasia is whether the corneal ectasia is stable or not. So the wear of contact lenses will not have any impact on the progression or not of the disease. So because many patients are asking, if I'm going to wear contact lenses, will that stop the progression of my disease? Not really. So wearing contact lenses will only improve the visual acuity, the vision of the patient, but will not have any impact on the prognosis of the disease. So if the ectasia is stable, then we have to see how we can improve the vision of the patient. If the ectasia is progressive, we should perform cross-linking to stop the progression of the disease. The only way you have today to stop the progression of corneal ectasia is cross-linking. there is some evidence that implanting rings alone without combination of cross-linking treatment can also stop the progression of the disease. This is a study done by Zeitz in Germany, and I think he's intending to publish this study soon, but it's not enough. We don't have evidence published in the literature, to put it this way, supporting this theory. So officially, it's just cross-linking that can stop the progression of corneectasia. So if we have a stable cornea, then we have several options, minimally invasive options, before proceeding to major interventions for improving visual acuity. Implantation of intracorneal rig segments is an option. We can discuss details later on each one of those. Combination of cross-linking with modified surface ablations, PRK or PTK, for example, or wavefront-guided ablations. Bruce has published, I think, his results, excellent results on this topic. And another option would be the Bowman layer transplantation. Actually, I don't believe in this procedure, but I have to mention that some surgeons are fans of, especially those who've been trained by Meles. And these minimally invasive procedures are actually for corneas, keratoconus, ectatic corneas, which are trapped in a gray zone between contact lenses. They have a bad visual acuity just to remain with contact lenses, or contact lens intolerance, and good enough not to perform corneal transplantation. But there are also patients with very advanced conus where we should proceed to grafting, deep anterior lamellar keratoplasty, or PK. What is better? There's another topic for debate, what is better for keratoconus. And of course, for funny ectatic diseases such as PMD or Terrien marginal degeneration, where we also have the typical features of ectasia with thinning of the cornea. There are different approaches such as lamellar crescentic keratoplasty, eccentric corneal wedge excisions, etc. There are many case series on these procedures, but these are procedures that you do not want to perform. The results are not good. So if I have to sum up, I would say that, and now I know that this debate will follow, but I have to say that keratoconus is very aggressive in children, so the consensus, I wouldn't say the consensus of the community, because in this case we have to cancel the debate. So I would say that in my personal point of view, cross-linking at the time of diagnosis is necessary for these patients. Transepithelial cross-linking is not as effective as epi-off nowadays. There are different approaches of transepithelial cross-linking. None of those is working as good as epi-off cross-linking. Now, the new trend in cross-linking treatment is the customized cross-linking, where we actually provide higher intensity in the area of the cone, and more specifically in the area of the posterior elevation of the cornea. So it's a more concept-focused treatment, and it seems that it's providing much more better results in terms of corneal flattening. So a combination of modified surface ablation with customized cross-linking is possibly one of the best options for visual rehabilitation in patients with mild to moderate keratoconus. Now, the scleral contact lenses is the best option for PMD patients if they can tolerate them, because surgical procedures could end up in nightmares. And don't forget that hormonal changes can affect the progression of the disease. So pregnancy is a major cause for deterioration of keratoconus. Also thyroid disease, for example. So we should always ask for these conditions when planning to perform a refractive procedure. So, as I said, I will not proceed to corneal dystrophies because of lack of time. If there are any questions?
Excellent. No, I think we have summarized most of the things within an hour and a half. For the anterior segment, I would like to thank the two speakers that gave us a lot of interesting tips and also some areas where we still have a lot of gray zones to overpass. My talk about the future will be in 6 months probably, or maybe 7 months in the Cataract Refractive Society of Greece, that we will do it in March. There's no point of doing it now. But I would like Dimitris to present his case, just to have 1 or 2 quick cases in Cornea Fan Club so that you will get some inspiration during your coffee. And by 11 we will finish up because we're already half an hour late, which is quite a success for a Greek meeting that starts at 8:30. Okay.